morning. My name is Edward Czerwinski. I am Professor Emeritus of Jagiellonian University and Senior Medical Director of FutureMeds. Welcome to Academy of Osteoporosis. This is the fourth lecture on the advanced diagnostics in osteoporosis. The previous was just on the basic diagnostics. In the previous lecture, I discussed the basic diagnostics of osteoporosis. Today, I will speak about advanced diagnostics on osteoporosis, means Trabecular Bone Score, the principles and application, X-ray morphometry, DEXA morphometry, and QCT, means Quantitative Computerized Tomography. We wish to see the structure, and we can watch it on the cross-section of femur. You see the cortex, the trabecular bone, the single trabecula. X-rays gives us some idea. We can just distinguish here this structure, and DEXA doesn't tell us much about the structure. We can just distinguish just that this is the cortical bone and there is something. And the same relates to spine. Here are the cross sections of spine, and here is the X-ray. We see many details like joints, processes, and not much on the DEXA scan. There's of bone have an input to resistance to fracture. So measurement and density is responsible just for 20%, remodeling of bone even less, and bone structure from 60 to 80%. So this is crucial to assess the bone structure. And here is the bone structure of the vertebra. Here is the beautiful structure with bone trabeculae and osteoporotic structure with porous. And I just construct the artificial trabeculae. Here we have 8 trabecules, and this is the scheme of the normal bone, and this is of the osteoporotic bone. And the bone density we measure by DEXA gives exactly the same results, 0.980, 0.980, because amount of trabeculae is the same, 1, 2, 3, and so on. But if we will do a scan just by which one X-ray, just single beam, so here we have a normal curve, like a very regular curve. It's painted by using a mouse. And here you see irregularity. And this is the key to TBS. That means trabecular bone structure. And these values are a calculation from the analysis spatial two-dimensional distribution of density pixels in DEXA image in fan bin compared to normal structure. So algorithm just takes care how much the structure is regular or irregular. And here it is, and here are 2 vertebrae with the same BMD, 0.9, 0.9, but a trabecular score for that one is 142 and one is 1.2. And here is a map of the normal good distribution, and here is this is the altered distribution. So this is the trabecular. We use this method in our laboratory. We have 39,000 tests, 15,000 patients, 15,000 women. We have normal bone structure, more than 1.32, partially degraded 131 to 123, and degraded less than 123. And here you have two our patients. This patient got TBS 1.4 and T-score for her spine is plus 1.5, had no fracture. And this lady, 72 years old, TBS is not 0.8, her BMD T-score is -1, and she have shaft fracture of the femur. And now we go to the principles of the program we talk about and how it works in fracture assessment. Here's our material, and you see 1,000 women, 244 with fracture, and here is the sensitivity and specificity. So you see, and in green is in TBS less than 1.3, and T-score less than 25. So you see there is a quite nice correlation. Here is another assessment of our material, and here is the limit for normal TBS. To the right, we have the positive, no disturbed. As you see, you have the better TBS, the less fracture. And on the left, you see that the majority of fractures, even 40%, is in the patients who have TBS lower than 132. That's this is other material. It is the study of my assistant, her doctorate already published in Jagiellonian University. And she analyzed 400 patients with mid-age 63, have DEXA questionnaire, so we knew the fracture, we knew the following fracture, and 30% fracture have no osteoporosis according to WHO, but 72 have TBA degraded. And here we have the diagnosis, mean osteoporosis, osteopenia, and normal. And here we have the normal structure. Here is the partially degraded, and here is the degraded. And you see that the more frequency of fracture was in a group with osteoporosis and degraded structure. TBS is implanted to FRAX. So here is one of a patient with a major osteoporotic fracture, just 11. And if we put the TBS adjusted, got 12, and hip fracture 4. So the better TBS, the fractures that will be smaller. The lowest TBS, the FRAX index will be higher. That's crucial. There are also many studies how TBS works in assessment of the efficacy of medication. And here you see placebo. And here is from the 0 state and change is TBS after 22 months is dropped down. Alendronate not much increase. Denosumab some increase. And you see how big increase of bone structure quality is on PTH derivatives. In clinical practice, TBS got already more than 6,000 publications in fracture risk assessment, medication, bisphosphonate, denosumab, teriparatide, albumin, secondary osteoporosis. We have that any DEXA scan can be used, and what the beauty is that you could use archive scans done then 10 years ago when TBS was not existed, and you can calculate it and compare. So huge application in endocrinology, hyperparathyroidism, in rheumatology, osteoarthritis, glucocorticosteroids, nephrology. So it's a really very variable method and should be applied in every densitometric laboratory. So this was the structure. And now the morphometry. I will start with the X-ray morphometry and then DEXA morphometry. What is for? The outcome of osteoporosis is fracture. So the criteria of drug efficacy is fracture prevention. To prove the fracture is the X-ray. So you use for spinal fracture and verification of treatment, diagnosis, and of course, differentiate diagnosis. Let's remind you that Dr. Röntgen discovered that 130 years ago. Is a German specialist. In Poland, we're not worse. He is in Krakow, the rector of our university, University, 1 year later. Any other Poznan, another orthopedic surgeon. And we have to be aware that 60% of spinal fracture are not diagnosed because they are painless, and always women are frightened and totally surprised if we do the morphometry and we said, listen, you got a vertebra broken. Let's remind you that after 50-25 have a fracture and half, almost age 88, have a fracture, the easiest way to diagnose the spinal fracture is measuring the height, of course. And if there is no difference, so you are sure that there is no fracture, 93%. If there is 1 centimeter in 3 years, it is 35%. And if there is 4 centimeter, it indicates the fracture. So we advise the patients beyond everything to measure her height. Just put the mark on the door and do it yearly. And if there is the 4 centimeter over 3 years, that means there is a spinal fracture. If you ask patient whether she has fracture and answer is I have any fracture, you don't know whether this is true or false, because 60% of the fracture don't hurt. So the next question should be, does your height decreased? But if she is on DEXA scan, so we measure the height, usually she doesn't know, but you have to inform her. So we do X-rays for fracture detection. And here is we do always 2 projection, the lumbar and thoracic spine. And if you zoom this image, you see that they are probably normal. I would tell, but here thoracic spine is not so easy to assess, and perhaps you are asking you whether there is a fracture or not. And if you zoom it, you see that I think that here is a fracture, perhaps here maybe not. So you have to measure. You just take a ruler and you measure. Surely now the computer does it, and you do it automatically, but even on the screen you can measure. And we have definition of the fracture, of the spinal fracture. how we do it. So there is always question whether this is deformity or fracture. Straightforward answer is that reduction of vertebral fracture by 20% means the fracture. Subject closed. How to measure? We measure in 3 points. We measure posterior height, medial height, and anterior height. And we calculate how the medial anterior height is differ from the posterior. If there is a broken posterior, we have the spine, the vertebral body above or below. So here is our patient, and we measure the posterior, means 30 millimeters. We measure the medial, 18 millimeters. We measure the anterior height, and now we calculate posterior minus medial divided by posterior, give it is 4, divided is 40%. That means this is the fracture, no doubts. And to do the X-ray morphometry, you need a good technician. You have to teach him, her, and there are also guidelines. There are manuals, and it is state of art. I would say it is not easy. The patient positioning might be very, very precise to get a good image, and we centralize in the thoracic spine TH7. Patient have to be very perpendicular, can be tilted, and just you got nice X-ray. And the same positioning for lumbar spine is also difficult. We centralize the X-ray beam on the L2 and asking holding breaths. It means we can find it 2 fingers above the rim of the pelvis. And so here we have the lumbar spine with many vertebrae broken. Everybody uses Genan classification, and it classifies as a mild from 20 to 25 is a mild fracture. A moderate fracture is above 25, and severe is more than 40. And as the shape is concerned, we have the wedge. That means the press of the anterior column, biconcave, the medial height, and crash if the posterior wall is broken as well. The general classification, remember, 20, 25, and 40. I am using this X-ray after Professor Papoulos. You have here 9 vertebral spine fractures, but only 2 are osteoporotic. I leave you. And I will put the answer somewhere in the net, so which is osteoporotic. The message is that this is a fracture of the spine is not necessary due to osteoporosis. Be cautious if there is single vertebra, because it may be just metastasis. I will be ashamed to not notice that and to not diagnose. So this was on morphometry using X-ray. And now the DEXA morphometry. If you have a fan beam, you have nice resolution, you can do the measurement. This is a densitometric image used only high voltage. So this is not dual energy. Dual energy will not give you such a good quality image. However, it is still not true X-ray image. And the program automatically finds down points, and it is very easy in the lumbar spine. It's very difficult in the thoracic spine due to vertebral shadows and lungs. And here we have the deformity, I mean posterior, medial, anterior, the posterior height, anterior wedge or biconcave. So here with the measurement of TH 6, and you see with the measurement that the anterior wall is much more smaller than the posterior. The posterior has in fact 18 millimeters, the anterior have 12, so there is a moderate fracture, wedge fracture, 29 degrees. I have another biconcave, mild fracture, 21. Okay, this method is, I would say, is excellent. It should be done every case. However, specificity for mild fracture is not very good. Moderate is super, and for severe is perfect, because the image is not as good as on X-ray, but we are saving radiation. The morphometry of the DEXA is 41 microsieverts, while X-ray of chest is 500, and lumbar spine 50, and morphometry even 800. However, today those values are much more smaller. Right. So this was the fracture detection, but we are really interested in the structure, and so we have only on DEXA gives us just the measurement, so we know the diagnosis, and I just told you in the previous lecture that take care, and I told you that please note that results are on square centimeter, bone mineral density square centimeter. It is nonsense for physical point of view, because our world, every mass have some volume. There is no just flat mass without any thickness, and so that the true specific density should be given in cubic centimeter, and this is the cubic centimeter I told you on the previous lecture. We can measure our body, our skeleton, obtaining the cubic centimeter using quantitative computerized tomography, because in a DEXA scan we got just flat surface of measurement. You can have only area, but here we have not pixel but voxel. Voxel got 3 dimensions and even have a density, so-called Hausfeld units. So this is a single cube obtained from any QCT and in quantitative QCT, and this voxel got some optical density expressed in Hausfeld units. And when we compare with the aluminum wedge, we got the true weight, I mean gram per square centimeter. And this is the QCT. Why we are using DEXA? I will just explain to you on my cartoon. So this is the cube, 1 centimeter width and height. So the mass is 0.25 milligram, and the volume is 1 cubic centimeter. So if there is a one cubic, so 1 cube, so the mass is 1,025, area is just 1, volume is S1, you do DEXA, the results are the same, not 25, not 220. If you put 2 cubes, you have 2 cubes, so we have area still 1 centimeter, but height is 2 centimeters. So the QCT will tell you, will divide by 2, got still 200, 200. But DEXA will measure all of them. Will give you 5, not 500. We got not 4. We have 4 cubic centimeters. So the area is 2. The volume is 4. So QCT will tell us is still a 1 cubic centimeter weight is not 250, but DEXA will say, oh, no, it is 500. That means DEXA lies. And even more, if we got 6 square centimeter, so DEXA will tell you the weight is 0.7 500, and QCT not for 250. If you have a patient with a very thick bones, so QCT will tell you that the cubic centimeter of this thick bone weighs not 250, but DEXA will tell you, oh, no, it's not 750. And that means you got information about the total mass, not about the specific mass. And surely this total mass better correlates with bones resistance to fracture. This is why we use the not realistic from the physical point of view measure density on the square centimeter. Again, you got square centimeter, and we have also, okay. But what we really wanted to know is the bone structure and just measure it with non-invasive methods. And the thickness of the one trabeculae is, say, 0.2 millimeters. For your imagination, this is the rim of paper sheets, 500, and got 50 millimeters, so one sheet got 0.1 millimeter. So the trabecula is just about 1 paper sheet. And the resolution of the method which we have, the X-ray standard can find it. DEXA absolutely not, but 2 millimeters, and FANBIN not 5 millimeters. QCT resolution, normal QCT standard is 0.5 millimeter. Multi-slice is even not 1/10 of the millimeter. We have high resolution QCT 0.7, not close to the trabecular dimension. We have microperipheral QCT, high resolution, which can have resolution 0.2 millimeters, so we can measure that single trabecula using equipment non-invasively. Going further, we have just in vivo standard, means micro tomography, just for bone biopsy, even 1 micron. And here there's high resolution tomography for the forearm, so you can measure that. And if you have a QCT, so you know the volume of the trabecula, volume of cortical bone, you can measure in separate way as you wish to. You can make very advanced research to the structure of the proximal femur. And as we know, each voxel position, the diameters, and the weight, the bone density, so we can calculate the bone strength, and you can calculate the resistance to bone to the stress. And here is how we can test it up in computer, having patient QCTs, whether what high risk of fracture she got, and this will be crucial in new medication assessment, because without bone biopsy, we can calculate the bone resistance to fracture. And that will be all for today. Just summing: TBS, trabecular bone structure, allow us indirect assessment of the quality of bone. However, this is not related to the true structure, which we can see on the microscope or high resolution peripheral QCT. TBS predicts fracture independently of BMD, improves accuracy of FRAX in fracture prediction. And we know that if the TBS is better, so the fracture is lower, and vice versa. TBS is used to predict the fracture, outcome of treatment, analyze abnormality of almost all diseases which touches bones. Spinal morphometry is more important than bone densitometry because detects the fracture. And 60% of fracture are asymptomatic. Remember, high loss of 4 centimeters indicates the fracture. Radiographic X-ray examination is the most accurate method as referral to any fracture, and can be also using the DEXA, and fracture threshold is 20%. DEXA morphometry is 25 for lower exposure and easier because we have a patient on the table you can measure. And exposure of microsevere is 40 in DEXA, and in spine, however, this value is limited much with nowadays modern equipment. Diagnostic is much more important than the T-score because we have the fracture and we know that patient who have a single fracture is at the risk of the next fracture. QCT, quantitative computerized tomography, allows to measure the actual density of bone expressed in cubic centimeter, and gives us method irrespectively to the whole volume, and contrary to DEXA, so why DEXA is preferred in the diagnosis of the osteoporosis. Quantitative tomography also measure separately cortical bone, trabecular bone, and knowing the mass of each voxel, its diameter and architecture, we can calculate bone resistance to fracture. And using the high resolution QCT peripheral with a very high resolution, 0.1 millimeter, so we can even measure the true bone trabecula and its structure. So this is a great progress. Saying that, I wish to thank you very much for your attention. I hope you like it. I invite you to the next lecture with fracture risk assessment. I would be obliged for your question, remarks, and pass the message to another colleagues. Bye-bye.